Dr. Rajiv Tukral to start the proceedings with his first lecture on pre-op workup and planning for a revision TKR.
All right, thanks. I hope you people can see my screen. I'm just going to be talking about the pre-op workup and planning. Even though he has given me only 5 minutes, I don't know if such a complex topic can be covered in that. But we must understand that the goals of revision are the same as the goals of a primary. We want to restore normal mechanical axis, joint line, achieve good fixation so that we can allow early functional stability and range of motion in spite of how it looks when we remove the older implants. So the challenges are many. There's a problem of soft tissues. There is a problem of orientation of bony landmarks. We need to somehow get bone stock back for reconstruction, and then we have to make sure we have good stability, mobility, and function. Early failure in most studies has been shown to be because of technical reasons, apart from infection. And the main thing we must understand when we're doing a revision is that if we can define the cause of failure, if we can permit the patient to undergo surgery physically as well as, of course, socioeconomically, because this is an expensive surgery. And if we have a good, experienced team with good equipment available and the patient's motivation is good, only then should we proceed to do a revision TCAR. Otherwise, we'll end up with the same problem as we started. So a good pre-op workup, the aims basically is first to determine the cause and the way that TKR has failed. What is left behind? The skin, the soft tissue cover, the bony defects, the ligamentous deficiency, and then plan your inventory accordingly. Sometimes you get odd cases like this. Of course, this is a very rare one. But understand that by failure, we are talking about a recurrence of pain, recurrence of the symptoms of knee instability or recurrent swellings in the knee. And there are both extrinsic causes as well as intrinsic causes. We must first rule out the extrinsic causes. And these can be from the hip, the spine, the vascular causes, even complex regional pain syndrome and others. But if you've made sure none of these exist, only then we look for the intrinsic causes, which are enlightened here. But understand, many times you can pick up infection because of the way it looks from outside. Even the X-ray picture may show loosening or lysis, but many times you can't. And that is where you need special investigations. Malalignment, whether it's in varus or valgus, is eventually going to fail. And that is why we are talking about CAS and robotics today. But even subtle malalignment, subtle instability should be picked up by stress test if you cannot see on a normal standing AB view. You need to do both varus valgus and sometimes anterior posterior push stress test to pick up instability. Aseptic loosening and wear usually occurs late, and you can see that in the form of gradual sinking of the prosthesis or wear out on one side of the joint, and that causes a lot of wear and tear. And sometimes when you go intraoperatively, you can find a lot of metallosis even if you delay surgery. Now, soft tissue impingements usually are picked up early. They are the early cause of instability. They cause like clunks or some tissues getting stuffed because of overstuffing, and they, of course, are treated separately. But one of the most tough sort of treatments is only going to happen for these extensor mechanism issues, which we must again identify and check whether they are the cause. Stress fractures usually occur either just intraoperative or immediately postoperative, and they are handled differently. But I put it up because all of these above causes will actually cause stiffness, whether it is a lack of extension, lack of flexion, or both, and we need to address this as well. So to work up properly, we need to have a proper working diagnosis. So we need to have a proper history as to the cause, the type, the area, and the way the pain behaves, the stiffness behaves, whether there's instability in addition. And that can be sort of reassessed with a good physical exam and good radiology, sometimes advanced radiology. Now, if you do a history, there are different ways you can check the timing of the complaints happening early or late, and then whether the pain is on weight-bearing startup pain or with full flexion or with standings or stairs or in full extension, and that all will differentiate which is the cause of the pain. Similarly, the mobility can be checked by the lack of extension and flexion, and there are different causes for that as well. Again, because of lack of time, I'm going fast. Now, physical examination involves checking for both coronal as well as sagittal laxity, and there's a special phenomena of a mid-flexion instability which has to be addressed separately. Normally, we do plain X-rays, standing, and sometimes we do stress X-rays, but we need to have good lateral X-rays, and sometimes we can also use templates to identify what size implants we want. Now, CT scans are done for rotational malalignment to look for rotational position of the components and for patellofemoral tracking. And sometimes you need to do MRI to look for extensor mechanism issues or to identify defects as seen in lysis. Pathology and microbiology, of course, are very, very important in infection and where you're doubtful, and that is a separate chapter in itself. So the details of the primary surgery are very important. If you can contact the primary surgeon and get to know whether the surgeon who did the first surgery used any modified approach or had some unexpected findings or unexpected incidents happening in TROP, requiring certain releases or required special closure. Also, for the size and type of processes to know whether that process is still available. Many times you are stuck because of that. And then we come up with a proper plan, which will then tell us whether we have to go with the same incision or the lateral most of the multiple incisions that you have, whether you need a plastic surgeon beforehand, whether you need extensile approaches, whether you will have to somehow compensate for the bony defect, which you will be left with after the extraction of the components, which is another principle, which I'm sure Dr. Arora will talk about, and the ligamentous deficiencies, which will require special implants. So you have different problems, but the process flow remains the same. You need to have a detailed history, physical exam, appropriate investigation, and keep adequate inventory, rarely customized implants. And the principles depend upon good preservation of bone and respecting of soft tissue, the same as you use for a normal or a primary knee. And of course, if you discuss this plan with your assistants who are a good active assistant, he will be aware and he will be able to help you. The take home messages, like 5 minutes. Ashish, I think I've completed in 5 minutes.
That's fine. So you
Thanks.
want to summarize?
I'm okay. I'm just trying to say that I was going to do that, is to prepare well by doing a proper detailed workup plan according to your workup. Know why the previous surgery has failed through a detailed history, physical exam, and ruling out other causes of pain, and then follow the basic reconstruction principles. Do not overextend your indications for a revision. Have adequate inventory available intraoperatively. If there are any questions, I'm happy to take them, or we can take them at the end of the session.
So I think we can take the questions in the end, and we can start with Dr. Arora's talk. So
But
he'll take us
in the
through.
meantime, before
Yeah.
he loads it, in the meantime, a minute or two, we can even have one or two
Yeah.
questions.
If there are
Because
any
at the end, they'll
questions,
forget the questions.
sure. So if there are any questions right now, you can unmute yourself and ask the question or put the question in the chat box, whichever way you're comfortable. So I can start the question to Dr. Tukral. When it's obvious, we know if it's a loosening or if it's an infection, then the plan is simple. So what will be your pre-op investigation for a case where you're not able to find the cause of pain?
So if you're not able to find the cause of pain, ideally you should not go ahead with the revision. You should be able to identify a cause. Otherwise, you'll end up with the same problem or you'll miss out on something. That's my first logic. The second, of course, is when you want to investigate to rule out infection, then of course, the basic tenements remain the same. You do a CBC with the ESR and a CRP, and then match them up with the clinical pictures. Always be prepared to do a two-stage and always prep the patient when you're not sure of the cause, because sometimes you find indolent infection or low-grade infection, and then you have to change your plan and drop. So go with a high index of suspicion of infection where you're not sure of the cause.
Rajiv,
Yeah.
it's a good summarize of the things in 5 minutes. For youngsters, always there is a big doubt whether is there any role for bone scan now in your in our clinical judgment or in our outpatient clinic. Do you or current literature says anything about that?
Yeah, so, this has been a very good debated point. Again and again, people have spoken about technetium labeled and gadolinium labeled and even indium labeled, WBC labeled bone scans. But in my practice, I don't use it as frequently, only to differentiate between, pure loosening and no loosening. So when it is aseptic or septic, loosening versus loosening is where I use the bone scan. To see increased uptake around the implant, I would say, okay, it's loosened, but I wouldn't be so sort of aggressive to pin it down to being infection or not.
Yeah, that's a good point. And also, the bone scan, which is done at least in the first 2 years, definitely it has got no role at all,
No
because
role.
in the first few years, definitely there will be some increased uptake due to the surgical inflammation, and even in the radiology meetings, they suggest that bone scan doesn't have any role nowadays to differentiate between, or in fact suspect any loosening also. They suggest of no
okay.
role for bone scan. So that will be the point. Anybody else would like to? Dr. Ajit?
How good is this ESR as a method of uh, judging infection? Because a lot of people put ESR as a standard thing, CBC, ESR, CRP.
Yes.
Yeah, sir, more than a single level of ESR, you look for rising ESR along with the rising CRP, or reducing ESR, reducing CRP as a primary indicator. And you have to couple that up with a clinical exam. I mean, you have got a patient who's got pain, unexplained, not ruled out by every other cause, and then you're looking at a rising trend of ESR or CRP. Even though there's no obvious infection, I would still put it as a subclinical infection
Actually,
and treat accordingly.
Yeah,
you have to allow me screen
that's
sharing.
correct. In a primary,
Course disabled.
in a primary situation, the ESR may not be that valuable, but the literature says, even the consensus says, if you are aspirating, particularly if you are suspecting infection and you are aspirating, the synovial fluid, what we aspirate, in that fluid, we have to send it for total count. And if that count is more than 3,000, and then in that count the CRP is positive, then it has got significance. More than 3,000 and the CRP, if it is positive, then it is. But ESR role is definitely, yes, not that reliable.
Then
Yes,
I think Dr. Rajkumar has also somewhat answered the question that Sandeep Serabat has put, whether we aspirate a knee in the case of suspected, periprosthetic joint infection. Now, if you ask me, if everything has been done and you're still doubtful, there's no harm in aspirating it, because
Yes.
you're going to go ahead and actually send that for cultures as well and look for a complete count and look for CRPs and match it with what you see clinically, radiologically. And accordingly, when you do surgery through that same, you will be anyways taking care of it. So I would say, yes, if you're in doubt, you should aspirate it, the knee. That's a question Sandeep has asked. If someone else disagrees, then they are welcome to say that.
I think we'll get going with Dr. Arora's presentation, because she's having issues with the link, I think.
Oh, okay.
So Dr. Arora, we can see your screen. If you're ready, so please go ahead and start your talk on exposure for revision TKR and basics and some tips and pearls regarding revision TKR.
Right. So let me put the video on. I'm sorry, it's getting dealing repeatedly. So in a revision scenario, you try to use the previous incision, and if there are multiple incisions, then you use the most lateral one. It's always nice to extend your incision about 1 centimeter distant, 1 centimeter proximal, so that you can get the normal planes and you can work upon. Once you have incised the skin, try to raise a flap, which consists of deep fascia as well, because you want to go deep to the deep fascia to avoid devascularization of the skin. Again, if you find it difficult to find the planes, go in the normal areas in the proximal and distal end of the flap. You raise flap on either side, and then majority of times you use medial parapatellar arthrotomy. This is what we use in the primary knee also. And once you have opened up the knee, you start debriding the knee on either side to remove adhesions. We start from the suprapatellar area. This was an infected knee. We were taking samples. You take samples from various areas if it is infected knee, and then gradually make gutters on the side, supromedial, supralateral, inframedial, infralateral. Now here, we are working on the lateral side around the tibia to create the gutter so that we can have an access to the implant, so that you can remove the tibial tray, you can have an access to the tibial tray, you go to the lateral side. One has to be very careful to respect ligamentum patella. And one can use banana peel, it's called as banana peel. You can peel off some part of periosteum on the lateral side as well. Similarly, you make a flap on the inframedial side and you remain subperiosteal. It is always nice to go around the corner, go to the posteromedial corner, because it makes life very simple when you flex the knee, if you have gone around the corner, down to the posteromedial area, once you flex the knee, it doesn't put much strain on the sleeve, softening the sleeve, and not much strain on the ligaments. Similarly, then you work in the proximal femoral area, and again here we'll raise subperiosteal sleeves on either side, taking care not to enter the collateral ligaments. Here we are working on the medial side and raising a subperiosteal sleeve. Now raising these sleeves make a life simple by exposure. When you flex the knee, there is not much soft tissue tension. You raise subperiosteal, gradually elevate on either side as per requirement, whatever is required, and remove additional on either side. And then gradually, very, very carefully flex the knee, holding the ligamentum patelli yourself. Don't ask your assistant to force or flex the knee, it might avert ligamentum patelli. You remove the insert. Once you remove the insert, you get a lot of space. And I think one of my colleagues will be talking on how to remove these implants. So you have enough space to work on now to remove the implants. Once you remove the implants, you have an access to the posterior capsule to the right, and whole knee is in front of you. Now, in case of if there is a lot of adhesions and if there is difficulty in subluxating patella on either side, one can resort to quadriceps snip. You require quite often in revision scenario, where you make an oblique incision in the rectus about 2 to 3 finger breadths above the superior pole of patella, obliquely at about 45-degree angle, along the lines of fibers of vastus lateralis. Once you do so, the lateral apparatus become quite easy to sublux on the lateral side, and it does not affect rehabilitation at all. In cases of severe patella baja, or if there is a stem and you want to remove, one can resort to tubercle osteotomy, wherein you raise a big flap of bone, a bone about 2.33 centimeter wide, about 1.5 centimeter in thickness, and about 7 to 7.5 to 8 centimeter in length, along with the tibial tubercle. And one has to be very careful. You go across on the lateral side, but you don't go all the way. You want to raise a flap where the periosteum is attached on the lateral side, and you don't want to go all the way on the lateral side. That preserves the vascularity of this tibial tubercle, osteotomy, large fragment, and very, very carefully you pry it open. This is a very old video. Now one can use osteotomes, one can use small saw, and very carefully, like in ETO, using multiple osteotomes, you pry it open, thinking onto the lateral side, and this preserves the vascularity. And now everything is in front of you. One can proximalize this fragment in case of severe patella baja to restore patellofemoral dynamics, and one can see everything in front of you. I think that's all about exposure. Permit me to give you my talk on, I think screen sharing has stopped, the shared window is closed. Okay, just give me a minute to please share my other talk.
In the meantime, can we take one or two questions in regards to
Please, absolutely, yes, no problem. Any questions you have, I'm happy to answer.
So, in your revisions, Dr. Arora, you will, if given a chance, you will prefer a quadriceps snip or a tibial tubercle osteotomy?
Quadriceps snip, very simple, doesn't affect rehabilitation unless it is severe patella baja, that the patella is almost near the tibial base plate and we want to proximalize the patella. Very rarely we use tibial tubercle osteotomy nowadays. Majority of cases, we are happy with doing quadriceps snip.
Another question, Dr. Arora, now that he's asked.
Yes, please.
In which case,
please.
actually, would you go ahead to do? Would you actually already plan that, okay, in this case, I am going to do a tibial tubercle osteotomy?
Oh, yes. Again, I told you, if it is severe patella baja, very rigid kind of, where you need more exposure, I usually do tibial tubercle osteotomy. Otherwise, quadriceps snip is always good enough. Almost 95% of cases is just a quadriceps snip.
No, so that means you decide at the time of surgery. You do not decide before surgery.
Before surgery, if it is too low lying patella, and I expect a lot of audible?
Yeah.
Yeah, now okay.
So have I answered the question here? Hello?
Yes, sir.
Some
Please go
issues
ahead.
with screen sharing.
You can, is my screen visible?
No, sir.
It got stopped now.
Visible, sir, visible? I am in OT, so there is a problem of, I think, signal here.
Sir, we got the first screen. You can try again.
Hold on, give me a minute here. Nothing visible, is it?
No.
Sorry for that, man.
Meanwhile, we can take a question from one of the audience.
Yeah, please.
So there was a question from Dr. Shashwat regarding the consensus about the number of samples that have to be taken in cases of suspected PJI. So anybody wants to answer this question?
Yeah, there
Can you
is.
repeat it?
Yeah, yes, go ahead, Rajiv or Dr. Arora, please.
Is my screen visible, Ashish?
Yes, sir. You're
Yes.
visible now.
You have to
What was
do
the question?
slide share, full screen, sir.
It is full screen. It's not full screen? It is full
Not
screen.
full screen yet.
Maybe there's some delay because of signal issue. Maybe some delay. It's already on my screen is full screen. I'll again, in the meantime, you can carry on with the question answer session.
Slideshow, you got to go.
Already done it, already done it.
Yes,
Like,
now
Now
you're
it's
okay,
okay,
sir.
sir. That's okay.
yeah, there is some delay because I did long way. If it is visible, I can go ahead with my talk.
Please go ahead, sir.
Yeah, thank you very much. Thank you. Apologies for all this because I've been OT and the signal issue is there. So restoring biomechanics in revision protein arthroplasty in fact a three-step process wherein it has got stuck. Yeah, three-step process wherein you first of all establish a stable tibial platform as step one. As step two, you stabilize the knee inflection by correct size and correct rotation of the femoral component and establish joint line inflection. And as a step three, you stabilize the knee in extension and establish a joint line in extension. So just diagrammatic depiction, step one, tibial platform, step two, balancing the knee inflection, and then in extension. And
Sir,
the fourth step
sorry
of,
to interrupt.
yeah,
Your screen is not visible. Just seeing the front, the first screen. You're not seeing anything
It's
else.
not moving. It's not moving forward.
so Dr. Rajkumar, I do not know, there must be delay here, and shall I log out and then you can go ahead with the next talk, I'll log in again.
Okay.
Yeah, please. If you permit me, I'll give my next talk. And
Yes,
in the
sir.
meantime,
We
Dr.
can do
Prash, you can
that
take the next
because
talk. Yeah, please.
yeah, it's
We'll not waste time. Please, I'll just exit and come back in again.
Sir, I would request you to stop sharing then and log in again. Will that be okay, sir?
Yeah, please, kindly. I'm just stopping. Give me a minute. Is it okay? Stop here.
So while Dr. Arora kind of logs in again, I would request and welcome Dr. A.S. Prasad to start his talk. He will cover extraction of well-fixed components and management of bone loss and revision TKR for us. So Dr. Prasad, if you're ready, please start sharing your screen.
Yeah, no. Now I'm trying same. I hope it has come.
We can see your screen, sir.
Yeah, great. So I'll start right away. So friends, thank you for having me here. And where Dr. Anil Arora has left, we'll start now. The first is try to assess the X-rays of the patient we are going to have the surgery on. It will tell us a lot of things. Just I'll make full screen and come back. It will tell us a lot of things about the X-rays by losing, and then we have to look for maybe there is stem, there are keel. So identify what we are going to have as armamentarium. We need a lot of patience. There's nothing, nothing to add on. This is absolutely essential. And exposure has to be liberal, as Dr. Arora said. The most important point, once we have exposed, try to expose all the borders of the implant. That's very important. Go all around of the tibia and femur. The femur posterior condyle we cannot access, definitely, but all the lateral and medial borders and the superior border has to be accessed of the implant. The idea is to find the right interface between the implant and the cement. And then for tibia, the stacking of osteotome, the osteotome have to be thin. Now there are flexible osteotome available everywhere, but we are using the osteotome which we use. And by just changing by one, going all around, we can try to remove or break the interface of the implant with the cement or the bone. Once it is done, we can remove it as we need, maybe, and we can simply push it away, or we can apply the implant extractor once we have loosened it with the osteotome and take it out. So tibia can be taken out this. On the femur side, for the I use giggly saw, and it is a very good device to take away the superior flange of the femur. And from the side, we try to use the osteotome and remove all the cement, or we are hitting the cement. So the idea is not to go into the bone, try to be in the interface where the implant and the cement interface is there. And once it is done, we can just try to hammer it from both the side, and the implant usually comes out. It may take some time, but it will come out. So that way we can remove all the tibia and the femur. If there are other issues, be prepared to do an osteotomy. And if you have seen that there's a stem and something. The whole idea is to preserve bone. Try to see that our implant doesn't come away with a lot of bone, and it can come with a lot of femoral condyle also. Assess it and then go on. Now we are coming to the how to handle the defects. The defects are only now assessed after we have removed all the fibrous tissue which is over the surface of the bone. We curate it out, remove it with the electrocautery, and once we have got all the bones exposed, then we assess what are the defects. The defects on both femoral side or the tibial side have been divided into 3 groups, and the grades are: 1, contained defects, the easiest to handle; the peripheral uncontained defects, which will again divided into stages depending upon the depth of the defect; and involvement of the ligaments and metaphyses, where it will be requiring a hinge anyway. So these are the 3 groups for revision. There are so many sub-classifications also, but this is very good practical classification. What are the issues in the revision? The defects have to support the implant. So the bone surface has to support the implant, and we have to restore the joint line. That's a very, very vital thing in any knee replacement surgery, and for revision it holds true. Reconstruction of the joint line is recognized as one of the most important factors in achieving normal ligament balancing and normal knee kinematics. The function will only come when we can restore. And in revisions, we have to be very, very sure we are able to do it. For fixation purposes, this zonal fixation concept, which has been given by Morgan Jones, luckily I have worked with him for my sleeves. I have worked with him twice. So he has come with the concept of 3 zones for revision: femur side and tibia side both. The zone 1 is the surface of the bone, that is tibia or femur. The zone 2 is metaphysis. So we have to have this good surface, and then you can keep the implant on the surface. In the metaphysis, there has to be some mechanism where the implant can be fixed to the metaphysis. And the third is diaphysis, a stem is there. To have an adequate fixation, we need to have minimum 2 solid zone fixation in an implant. And this concept is working very well everywhere, and we all follow it now. There's so many things available to do or take care of the bony defects. The cancellous bone for filing or compacted, the impaction grafting in a contained defect, the cement, the screws, the rotor system, the bulk grafts, metallic augment, sleeves, that's my favorite, and stem definitely has been working all the time, and the hinge one, where you have to replace the ligaments also. Again, Dawes principle for grafting will not go into detail, but the local bone resected femoral condyle can work as a good adequate bone graft and works very well in primary knees, not in revision. Shaping is possible and it can be fixed with a screw, and even small buttress plate can be applied to hold it there. Like this, we have used it, but normally it is required in the primary graft. We have to prepare a good surface. If the surface is not even, we have to use augments so that the implant sits on the bony surface, and the augments work very well. The wedges are there, they can also work very well, and they can elevate the joint line so that the joint line can be restored. And we can take help of everything like this. Sleeves are my favorite, and I'll go into detail, but there's another lecture on the sleeves, so details will be worked up there. The cones I have never used, but I have seen them being used, but they do not match sleeves because sleeves serves another purpose. Cones are basically a bone fillers. They sit there and the implant can be fitted with a stem over them. So they fill the void inside the bone. My idea is to use a sleeve, and all the time it is working very well for years now. Like this patient has so much of bony defects you can see on the tibia side. And the joint surface has to be elevated much higher to considering to the defect. The augments may not hold, but if we apply a sleeve, the sleeve, if it is fitted well into the metaphyseal region with a stem that is zone 2 and zone 3, we can have the plate hanging above the bone and still it will work very well, like this. That's pure zone 2 and zone 3 fixation, and it gives a solid functional capability, and we can restore the joint line also. And this works in so many cases. If we look at the sleeve, the advantage is while doing trial, the anterior part of the sleeve is fitted in the bone, this size 2. Once we have compacted the bone, fitted the trial, the rotation of the tibial tray can be adjusted as we want. The 20-degree here or there, it can be easily rotated. So the rotation doesn't have to be rigidly on the anterior side of the sleeve. That's the leeway we have, and we can utilize very well to get good functional rotational outcome or rotational position of the tray, irrespective of in which position the sleeve has been fixed. Some users like this patient, it was done by me only, but way back, but after only 16 years, came with such a picture. And that fellow had a history of injury. We thought everything because the patella I do not do normally now, and he had erosion of the patellar surface also. Anyway, when the injury which had happened 1 year back probably had broken the plastic, which this is the extracted one, and led to all the erosion. So the surface of the bone is not adequate, whether it's on femur side or the tibia side. So zone 1 will be lacking, but zone 2 and zone 3 were used, and definitely patella has to be replaced as well. So this is what we got, zone 2 and zone 3. And similarly, it's again my case, done way back. It's Apollo knee. I think many of people may not have seen this. But again, after 22 years, this has happened again. On the femur side, we could manage only zone 3 and zone 1. No metaphyseal fixation because the surface was good. But on the tibia side, it was again zone 2 and zone 3. So this combination works very well. And if necessary, we can go for only zone 3 and zone 1 if the surface is good. This again a revision I have done, and again I have to use zone 2 and zone 3. The important thing is that we can use sleeves without stem. While on the trials, when we are doing a trial, the stem has to be used, a trialing stem, so that the alignment can be used. Alignment is perfect of the sleeve direction. If the zone 1 is good and the zone 2 fixation is good, then we can leave away the stem. But that's not a rule. This is an exception. It was a specific case. We had to use a cemented stem, a very small lady, small built lady. So this is exceptionally when in that thing, yes, we can do it. But don't take it that is a rule. This is just a conceptual thing that yes, we are using 2-zone fixation here also. And sometimes we land with such a case. This lady was referred to me from other side, and probably the doctor was, while removing the implant, had to do an osteotomy. But this is how we will handle. So naturally, we had to go and do a proper rotating hinge. There's so much of defect, and we had to replace distal femur also, and this is what we did. So friends, handling defects is not easy thing, but it's not difficult as well. If you know the concept and the armamentarium is good, the sleeve single-handedly has done a very good thing for our surgical adventures, which we were doing before. We had been using a stem for years together, but since we are using a sleeve, it is working very well. And rotating platform is another thing which is giving a lot of good results, and longevity is the most important. Thank you. Thanks a lot.
Thank you, sir. Thank you for your excellent lecture. So, while the next speaker, Dr. Arora, are you ready for the talk, or sir, you'll have to unmute?
Yeah, I've done so. So, am I audible now? Am I audible here, Archie?
Yes, sir.
Yeah,
There's some lag. Yeah.
Permit me to share my screen now.
Yes, sir. Please share the screen. Meanwhile, we'll take questions from Dr. Prasad.
Permit me to, because you have to enable to share me the screen.
Oh,
Most
okay.
disabled screen sharing. So you have to
Done,
permit me
sir.
here.
Done.
Thank you, sir. Thank you very much.
So, Dr. Prasad, one question for you.
Yeah.
What's the sequence of removal of implants, sir? Do you have any particular sequence, tibia first or femur first, or what would you suggest? What would you advise?
Ideally, the first thing is to remove the insert, as Dr. Anil Arora said, then we can get a lot of place. Then usually I remove the femur then, because we have got a tibial support, and I try to use the femur first. That takes most of the time. Tibia
Right.
removal is usually simpler, and I'll keep it last. But there's no hard and fast rule. If necessary, if tibia is looking loose, then why leave it there? First, I'll remove it tibia, keep the plate back, and then remove the femur.
Right, sir. So, as a general rule, we can think of femur first can be the basic rule for a well-fixed implant. Will that be okay to, or fair to say?
Yeah, yes.
Right, sir. And sir, what is your thoughts on usage of stem or use of cement in cases of cementing the stem? So where to use this? How to use the cement for fixation in revision TKR scenario?
Normally, I use uncemented stem because cemented stem again will be the exception.
Okay. And I saw the case where you have put cement in that sleeve. Can you just put some more light on that?
Actually, the size, the smallest sleeve, it is to be cemented. So that's why the cemented has been done. The smallest size of sleeve which is available, the direction is that it will be used with cement. It doesn't have so much of fixation.
Okay. Okay. So point taken, sir. So any more questions for Dr. Prasad, or we can proceed with Dr. Arora's talk?
My screen visible, Archie.
Yes, sir, you are visible.
So great, so great. So coming back, if you permit, I'll go ahead with my talk.
Sure, sir. Let's proceed, sir.
So restoring again is a three-step process I was talking about. Step one is to establish stable tibial platform, and it's as a step two, you stabilize the knee inflection first by correct size and correct rotation of the femoral component, and you establish joint line inflection. And as a step three, stabilize the knee in extension and establish joint line in extension. And the fourth step of restoring patellofemoral dynamics automatically goes hand in hand when you are doing this, all these steps. So we establish stable tibial platform as the first step because tibial articular surface articulates throughout the joint position. And this is the platform on which to rebuild the knee. Just to remind you, I'm talking of tibial platform and I'm not talking of joint line. Tibial platform is the top surface of tibia I'm talking of. So use medullary canal as a landmark, and you square up the tibial surface by using an intramedullary tibial cutting guide or top end of the sleeve. Once you have squared up the surface of tibia, you go on to the step two, to stabilize the knee inflection. By these 3 steps, just a humble reminder that in revision scenario, the flexion gap is much, much more than the extension gap, and you need to fill up the large flexion gap. So you choose the size of the femoral component that is going to stabilize the flexion, the knee inflection. Just a warning, it is a very common error that you measure the bone, existing bone, and simply fit the corresponding femoral component. In 99% cases, if you do so, it will be smaller than the required size. And if you put a smaller femoral component and you try to fill up the flexion gap with poly, once you bring it into extension, you're bound to raise the joint line. And if you don't use a thicker poly, you will leave the knee unstable inflection. So we need a proper size of femoral component. How to choose correct size? See, one is you get some idea from the failed component, but more important is that the flexion gap is dictated mainly by the collateral ligaments in the revision scenario. You lift up and see. One can see that how much is the flexion gap and how much you have to fill it up. Now, what limits the size of the femoral component? One is the medial-lateral dimension of the femur, and second is compatibility of the femoral component of the pre-chosen tibial tree already chosen as a step one. What are other methods to fill up the flexion gap? Large flexion gap is translation of the femoral component by using offset stem or short cemented stem, or one can use translation given by some companies like TC3, or one can use large femoral component with augments. This is how you try to fill up a large flexion gap. Now, once you have taken up the proper size, seat the femoral component in proper external rotation, taking epicondylar axis, or better, the tibial cut. You can put it parallel to the tibial cut surface for better patellar tracking. Now, restoration joint line, I will not put much of, because Dr. Prasad has already pointed it out. It's very, very important. It is paramount to make every effort to restore prosthetic joint line near to natural. If you elevate, there'll be a problem. How do you do it? What are the tips? See, when the knees flex, your joint line should be distal to the lower pole of patella. This is what is desirable. You should make every effort to bring your joint line distal to the lower pole of patella. Just giving you 2 scenarios. On your left, there's a small femoral component and a thicker poly, but if you see the joint line, it is at the lower pole of patella. On the contrary, we have here on the right side, you have a larger femoral component permissible and a thinner poly, and you are distal to the lower pole of patella, and situation on the right is more acceptable and better. Another practical point, if your patella is within 1 centimeter of the top end of the femoral component, more often than not, you are right in establishing the joint line. You'll be correct in establishing the joint line. Do we have other measurable parameters? There are various parameters given in literature, but I think they are not that particular, because for every femoral size, they will vary. If you see literature, one parameter has stood test of time, that is the so-called adductor tubercle joint line distance, or the adductor ratio. Now, what is the adductor ratio? Adductor ratio says that the distance of joint line in extension from adductor tubercle is almost 50% of the femoral width at the level of inter-epicondylar area. To be precise, it is 52%. So one can measure the femoral width intraoperatively, and 52% of this width is distal our joint line, distal to it, distal to adductor tubercle. Adductor tubercle is I put a needle to just to make you see. It is adductor tubercle, about 52% of the width of the femur at intraepicondylar area is the joint line. It's how much distal. And there are various studies available in literature where adductor ratio has been quite okay in almost 92% of cases. Now, once you stabilize the knee inflection, you stabilize the knee in extension by matching extension gap to the flexion gap by using already selected femoral component size and poly thickness. We neither want recurvatum nor a flexion contracture. If there is residual flexion, you take it this cotton femur, but if it is recurvatum, then don't fill it with poly. If you do so, again, you will raise the joint line. If there's recurvatum, then you can distalize the femur by using augments or a sleeve, or if you're using sleeve, a larger sleeve. So once you have matched the extension gap with the flexion gap with good patellar tracking, you are through with the basic steps. And again, as Dr. Prasad said, that you need to have at least good fixation in 2 zones. Thank you very much. Any question, I'll be happy to answer.
Dr. Ashish, unmute yourself, please.
Sorry. So thank you, sir. Thank you for a great talk. And there's a question in the chat box from Dr. Ankur Singhal, who wants to know if the adductor joint line ratio is measured in extension or flexion. So if you could please elaborate on that point.
Right. So we are talking of joint line in extension as well as in flexion, right? I showed you only in extension. So we are measuring the distal X in, see, it doesn't matter how do you measure it. We are talking in extended position, the joint line from adductor tubercle is 52% of the femoral width. And the joint line in flexion, when we are talking of going posteriorly, is 1/3. I did not elaborate here, just not to confuse. So no matter how do we measure it, but when we talk of flexion, we are talking of posterior joint line, and we talk of distal joint line extension, we are talking from adductor tubercle to distal end of the femur. Is it clear, or shall I clarify it more? You can measure in a flexed femur, but from adductor tubercle going distally, your distal cut or your distal end of the femoral component is 52% of the femoral width.
Okay.
Posterior condyles, lower border of the posterior condyle of the femur would be 1/3 of the femoral width at interapicondylar area.
Okay.
The distal portion is end up. Is it
Thank
clear?
you.
Right.
Yeah. Right.
So, I would invite the next speaker to upload his talk. The speaker will be Dr. Chandrasekhar, and he'll talk about gap balancing in revision TKR and how to choose between the varus valgus constraint and hinge.
Good evening, everyone. Thank you very much, first of all, for having me in this webinar. So the talk is about gap balancing and levels of constraint in revision total knee arthroplasty. The goals of reconstruction have been already explained in the previous talks. They remain the same as for any primary total knee arthroplasty. What we have to understand is constraint and balance are 2 fundamental concepts, but they are quite distinct from each other. Constraint is not the same as balance, like a lot of people get confused between them. And the basic tenement of any revision arthroplasty is to get away with the least possible constraint and achieve the best possible or the maximum balance. So this is actually a trade-off. Constraint is a trade-off between a stable fixation for the implant, the longevity of the revision prosthesis, and what amount of balance you're going to achieve. So balance is basically a dynamic concept which is reliant on intact ligament function. So only if you have a ligament which is functioning, then you can achieve a good balance. If the ligaments are deficient, then you have to rely on implant and bearing designs or modifications in the bearing designs to substitute for the absent ligaments. Ultimately, the goal is to achieve a functional stability, which is a sum of a balanced joint, and if necessary, you increase the constraint to improve the stability. So how to achieve maximum balance during revision surgery? Most of these points have been covered by Professor Arora in the previous talk. First thing is to establish a stable platform, identify and restore the joint line both in flexion and extension. And the idea is to fill the bone defects. Don't go to the point where there is a bone defect, but fill the defect with either augment sleeves or cones and assess stability in the coronal and the sagittal plane and correct the rotational malalignment. And at the end of it, you add the constraint depending on the ligamentous tension. So I will not go into the details of these because this has already been covered in the previous talk. So there are some surrogate markers like meniscal scars and 1 finger breadth above fibular head and below inferior pole of patella, which are again not very reliable. Adductor ratio has been extensively discussed in the previous talk, so I will not go through this again. So most of the revision scenarios pose with flexion extension mismatch, and typically the flexion gap is much more than the extension gap. And one way of how you can balance the flexion gap is to flex the femoral component. And it's been shown that by flexing the femoral component by about 5 degrees, it will close the gap by around 7.8 mm. There are other methods to close the flexion gap. One is by upsizing the femoral component, and you can build up the defect in the posterior condylar offset by using augments and reducing the tibial slope. And subsequently, if there is any extension mismatch, you can make additional distal femoral cut and make use of augments in the distal femur as well, and increase the polythickness so that you can balance both the flexion and extension gaps. So depending on the type of instability, you can face with different scenarios. As I said in the beginning of the talk, don't try to increase the constraint at the beginning. So try to establish what is the reason for the instability, whether the instability is because of a defect in the bone. So if you have a defect in the bone, it can be got away with by filling the bone defects, but don't need to increase the constraint. And the type 2 type of instability is where you have ligament and soft tissue deficiency. And type 3 is a composite variety where there is ligament and bony defect as well. This is a very, very useful classification to plan as to what sort of constraint you're going to use. So type 1 are the bony defects, where the simplest solution is to reconstruct the joint line. So if it is type 1A, it is called as an acute one, where there is a malposition of the components. So the simplest solution is to correct the malposition and use a minimal possible constraint in this. And type 1B is a late instability, which happens because of subsidence and loosening. Again, the principle is to reconstruct the joint line and build the bone defect and use the constraint as per the requirement. Type 2 are the little more complex varieties where there is a soft tissue deficiency. Type 2A, ligament deficiency, usually the MCL. And depending on the individual situation, you can go for a VVC type of implant or a rotating hinge. And type 2B is a little bit more complex, where there is a concomitant extensor deficiency as well. This is a situation where there is a global instability. And this is a situation where you have to go for a rotating hinge. And sometimes you can face patients with poliomyelitis or neuromuscular issues, where there can be severe recurvatum or extensor deficiency. You may have to consider using a fixed hinge in these cases. And type 3 are the ones where you have to go for a hinge because there is significant bone loss associated with a ligamentous deficiency as well. As I said, type 1A, where there is a malposition, there's a varus in the component. This can be managed with correcting the malposition and using the least possible constraint. This is one of my cases where the patient had a subsidence, bone loss, and late instability. This was referred to me a couple of years ago, where patient had loosening. And as you can see, though the preoperative X-ray looks quite bad, but there is not much of ligamentous problem in this case. You can get away with a VVC type of implant. No need to go for a hinge in this case because the collaterals are good. And this is a stage 2 revision scenario. Again, the collaterals are intact in this case. You can see there is reasonably good bone stock. So you can get away with a simple constraint in this case, where there is not much of ligamentous problem. This is another patient who had early loosening on the left side. And on the left side, you can see, even on the preoperative X-ray, that there is significant subsidence, both on the femoral and the tibial side. And the femur seems to be quite oversized and quite significant bone defect in this. This is the intraoperative picture. There was quite significant opening on the medial aspect. MCL was completely deficient, and the implant was very loose. It just came off into the hands, and there was not much of bone stock left. So I reconstructed the condyles with bone graft and screws. Because the MCL was deficient, I had to go for a hinge in this case. So this gave a stable fixation to the patient. If you are faced with a situation of recurvatum and global instability, then hinge is the only option. You can't get away with a VVC type of an implant. This is another case which was referred to me as a second stage. Patient had a surgery about 16 years ago. As you can see, there is quite extensive osteolysis on the femoral side and the tibial side. And the patient had infection and had a first stage revision elsewhere, where they had removed the implants and put a articulating cement spacer. So when I removed this spacer, I was left with significant bone loss and also deficient soft tissues, as you can see. And this is all was left on the femoral side. And the patient is 82-year-old. And this kind of a scenario where there is significant bone loss and also defective collaterals and hardly any bone stock left. I don't think any kind of using bone filling devices like sleeves or cones will work in this case. So I went for a distal femoral replacement in this patient. The patient had an excellent outcome, and this is him walking 3 weeks post surgery. So in summary, you have to identify what is the reason for the revision, whether it is you're dealing with a bone defect or a ligamentous deficiency, or it is a combination of bone defect and a ligamentous deficiency. If it is just a bone defect and malpositioning of the components, you generally don't require to increase the constraint. However, if there is an intermediate collateral deficiency, then you have to go for a VVC type of implant, and significant collateral deficiency, rotating hinge. If it is associated with extensor disruption, either a rotating hinge or a fixed hinge. But the basic mantra is use the minimal constraint to achieve the maximum balance in a revision scenario. Thank you.
Excellent talk, Dr. Chandrasekhar. So a lot of information for the audience. There's one question that I would like you to answer. If a patient has come with a failed LCL, what will be your preferred constraint?
Yeah. So usually, I mean, unlike the MCL, the LCL is a little bit more forgiving because there are a lot more structures on the lateral side. So those
sorry,
generally,
Chandrasekhar, can you stop sharing so that the next
yeah,
speaker?
sure. So usually if it is an MCL deficient knee, then you straight away consider going for
Unmesh, can you load the screen?
Yes.
But with LCL deficiency, I think you can still get away with a VVC type of a prosthesis.
It shows host as a disabled screen. So
What's happening?
a host has a disabled screen.
No, 1 second, 1 second.
Okay. Oh, now I can see that. Yeah.
Yeah.
Can load it. Yeah. Okay.
Yep. Yes, Chandrasekhar, please go ahead.
If it is a lateral side instability, then usually we can get away with a VVC type of implant rather than going for a hinge in that case. Unlike the MCL, because on the lateral side there are a lot more supporting structures with your posterior oblique ligament and then the popliteus, apart from the LCL.
Yeah. Good. Chandrasekhar, in the meantime, when the other talk is going on, there are few questions in the chat box pertaining to your talk.
Yeah.
If you can answer that, in the
Sure,
meantime, Dr. Unmesh can start his talk.
Hi. Thank you so much. Thank you, Dr. Ajit and team, for asking me to talk on this webinar. So my topic is armamentarium for revision TKA. The important part is be prepared for the worst than what you anticipate. I think in all revision scenarios, things can be really worse than what you can anticipate beforehand. What challenges we have? We have bone loss because of infection, osteolysis, and mechanical damage because of loosening component. And we have soft tissue issues with MCL, LCL, quadriceps, or patellar tendon. So first of all, implant removal, you should have all the set what is required. A cement picking up things, cement removal set. A recip saw is very good for removing the femoral component very quickly. You just go within the cement and the bone and the things will come up very easily. So these are the important part to remove the implant as been talked before. Of course, the bone defects can be talked about. And what we require is something which can fit into epiphysis, metaphysis, and diaphysis, zone 1, 2, 3 in our armamentarium. So what options we have today? We have a standard wedges like this. We have a sleeves, we have cones, we have half wedges, we have a hinge, and we have a distal femoral replacement or a tibial replacement. So these are the options we have today with us to deal with the defects. Of course, when you look at the zone 1, we have femoral augments, basically to increase, as Dr. Arora has mentioned, to distalize the femur, to increase the size of femur, to fill the defects in extension or in flexion, depending upon the posterior augments or the distal augments. It can come in 4, 8, and 12 millimeters. We have tibial wedges, which can be 5 or 10 or 15. Of course, you can't use the wedges with sleeves. If you're using a sleeves, it has to be only sleeves, no wedges to be used. Wedge can be used only if your defect is very small and can be on one side, medial or lateral. Of course, when you look at sleeves and cone, fixation is zone 2. The important part of sleeves is made of titanium. It has most taper, so no cement required in most of the sleeves, unless it's a very small size. It gives a rotational stability and it gives a lot of bone fixation and augmentation. So it's basically a fixation method with augmentation, while titanium cone is basically high volume porosity, low modulus of elasticity, high friction characteristic, but it has only augmentation purpose. It cannot give actually like what you have sleeves, which can be a fixation method and on which we can put a tibia and the femur. The stems, of course, for zone 3, we have stems which can be fluted in uncemented types, both tibial and the femoral side. Cemented can be only 30 or 60 millimeters, but I think most of people in the revision scenario will be using, unless it's really osteoporotic, will be using a sleeves and or cone with the stem. I think uncemented stem is the most commonly used compared to cemented stem in the revision scenario. So when you look at the fixation part and everything, we have 3 fixations. Here you can see zone 1, 2, 3. And for that, so we have, for zone, we have sleeve, the augments, distal femoral augment, posterior augments, or a tibial wedges. For zone 2, we have sleeves and we have cones. Of course, sleeves are more better than the cones in terms of fixation and stability together. And for zone 3, we have stems. So we have 3 things for 3 zones, and with things together, I think we can reconstruct very well. I'll just use examples. Using a half wedge for tibia, if only tibia collapse was there in this patient, where we use the tibial half wedge with a cement, it worked very well for it. No change of femur required or no change in terms of constraint. Here, I use basically a 2-stage infection. So first stage, we do a cement spacer. This artificial spacer made by autoclave implants, and the TC3 is a rotating platform insert. Here we have used distal femoral augments and sleeves together to achieve a good stable fixation. One more case, as we say, I say aseptic loosening, lot of loosening with a lot of bone loss on tibia and femur both. It just fell on basically on table. Here we used both sleeves on both sides and fixation with mainly zone 2 and zone 3 fixation and everything, and you can see a good result 2 years down the line. Here, one more patient with a loosening, of course, with a fall and collapse of the tibia. Here, I use sleeves on both sides, femur on the tibia with excellent outcome. With the sleeves, you can elevate the joint line so much. Don't have to use much a large poly, maybe 15 or 16 or 50 or 70 is good enough in most patients. So sleeves is really a great thing to have in your armamentarium. Of course, though it adds to a cost, is one of the best things to have. Of course, hinge. I had this patient who had exchange completely failure in hyperextension. He's going 30 degrees hyperextension. We tried initial with constraint device and then end up putting a hinge for him. When you're in hyperextension or anything like that, you have to have a hinge, or when you have a MCL deficiency. Thank you so much.
Thank you, sir. Thank you for your excellent talk. If I may ask you to just summarize in 5 points, your top 5 points for revision implants.
I think I will be first, prepare for the worst. Make sure you have everything together, including the sleeve on table. If you are worried about the MCL intactness. Secondly, the most workhorse for me is sleeves. Of course, the stems and augments. So you should have all those things. It comes with a cost, but I think sleeve can be a great saver for getting the joint line right, getting the tibia elevated without much of a lot of cement to put in, and it gives a solid fixation. You can mobilize the patient immediately. So I think sleeves is the workhorse to get the joint line right, along with augments and a standard implants. Of course, backup has to be TC3 as a hinge, all cases.
Right, sir. So I would like you to stop staring, and I would like the next speaker, Dr. Sujit, to start sharing his screen. Meanwhile, we can take a couple of questions.
Dr. Unmesh, just one quick indication. The indication for cones is the sleeve is not a viable option. The indication for cones.
I have not used cone honestly.
Okay.
What is on course? Anything else? What you can say? What you can
Yeah.
suggest?
The metaphyseal bone loss, a huge metaphyseal bone loss. The proximal bone loss, yes, most of the time. Sometimes even the largest cone sleeve may not be a good option. So here we have to use this cone as a bone filler. So like we put the sleeve and have a good the bone some filler like a big sleeve component because it has got a good titanium. Now the good point is we need not rely on the Zimmer cones. Nowadays, India itself, we have some cheaper cones available, and particularly the sizes are smaller. The problem with the Zimmer cones, the sizes are very huge. They are for Caucasians.
Yes.
For Indians, the small sizes have come, and that helps us to build that bone. And then the advantage is that we can cement the stem through the cones.
Okay.
So the bony integration also is very good with that cones. So in that cases, we can use cones.
All right. Okay. Thank you.
Particularly in femur, it helps in
Yes.
femur.
Okay. Yeah.
So great points. So now we have Dr. Sujit Tripathi. He will take us through the stage 1 revision for a infected knee, and he will talk about various options for antibiotic spacers as well. So please, Dr. Sujit, the stage is yours. Please proceed.
Yeah, thank you, Dr. Ashish. So, good evening, participants and faculties. Today I'll be speaking about the stage 1 revision with antibiotic spacer applications. So this is just a brief history of one of our patient who was operated recently. He was operated outside in 2023 September, where the right TCAR was done. Then subsequently it got infected and he was debrided outside. The diet procedure performed in February 2024. The culture report shows growth of Staphylococcus aureus, but it was that means sensitive to all the methicillin group of antibiotic or the penicillin group of antibiotic. And subsequently, he was continuously on and off antibiotics with different forms of antibiotics were given. He presented to us last month only with pain, swelling, and stiffness of the right knee. And there is a joint was warm to touch, tender, range of motion was around 30 to 60 degree. We proceeded with all the investigation where we found a raised inflammatory markers and the synovial fluid aspirate showed a raised leukocytosis and polymorphonuclear cells was around more than 80%. So this was the clinical pictures and radiological image. You can find that there is a osteolysis just on the medial side of the tibia, just beneath the tibial base plate on the medial side. And the knee joint is stiff and there is a swelling at the proximal part of tibia just below the incision line. So I will go through this video where we can see how I have performed the first stage revision. So this is the X-ray. Before deciding the incision, you should choose the most lateral one. And it is not a limited incision. You have to give a big incision. And as there was a swelling in the proximal part of tibia, we incised up to that level. And you can see the organized pus coming out through that abscess. There is a swelling there in the proximal part of tibia. And this was the organized pus that came out from that particular swelling. We send it for the culture. Then we perform the medial arthrotomy as described previously by the previous speakers. So here the main problem is such stiff knee which has been operated once or twice is adhesion. So whole of the quadriceps is totally stuck to the femur on the proximal side. And sometimes the patellar ligament also, the patellar tendon also is adherent to the proximal part of tibia. So you need to remove all these adhesions and at the same time you need to send the synovial fluid or whatever material comes inside the joint for culture sensitivity and for subsequent evaluation of that particular thing. So after doing that, you need to release everything on the medial side. The adhesion has to be removed from the proximal part and then the distal part. And similarly, remove the adhesions from the below the patella. At the same time, one need to do the peel out the medial part of the MCL, particularly the deep part of MCL has to be released because you need to flex and subluxate the joint. So once that is being done, then you can subluxate the joint. And once that is done, the sequence of removal of the process that you need to remove the tibial insert first. And that you can remove by just tapping at the junction between the tibial base plate and the insert and it will come out. The sequence subsequently is the femur component and the femur component need to be debonded from anterior to posterior, come from the anterior cut, then the anterior chamfer cut, then the distal femoral cut, posterior chamfer cut, and the posterior cut. First, we debonded it with actually first we debonded it with saw, and subsequently we used osteotome. So on both the sides, medial and lateral side, you need to debond it. And then once it has been debonded with the saw, then you can use a small osteotome or chisel for breakage of all the adhesions there, basically between the cement and bone, cement and the implant interface. So never aim at between the cement and bone interface. The interface is between cement and the implant. And you can use a giggly saw to debond on the anterior side, and you can go up to the anterior chamfer, but not below that. And it should be upwardly directed because sometimes it may take a chunk of bone along with it. And then simultaneously, two person can disengage the femoral component on both the sides with equal force, so that there will be no excessive bone loss while hammering it out. And at the same time, one of the extractor can be used to remove that, so that there will be minimal bone loss and there will be symmetric force on both the medial and lateral side. So this is how once the femoral component is removed, then one should proceed for the tibia. Again, the same sequence with this saw. Actually, you need to debond between the cement and the implant interface. Then with a chisel or osteotome, you need to debond it. And one can use the stack osteotome method as mentioned by Dr. Prasad previously. And sometimes what we do, we over the one osteotome, we put the over another osteotome just to give traction so that there will be minimal bone damage. So it should be done on the four corners of the tibial base plate, basically on the anteromedial, posteromedial, anterolateral, and posterolateral. Easily the component can come out. Once the components come here, you can see that there is very minimal bone loss is there, and this is how whole of the component come with very minimal bone loss. Then you need to remove whole of the cement there, and with a chisel or small osteotome, you need to remove the plug also on both the sides, particularly for the tibia side. And once the cement is curated out or removed out from both the femoral and tibial side, then you need to wash it thoroughly, and you can remove all the gutter also, medial gutter, lateral gutter, suprapatellar pouch, and the posterior aspect of the knee joint, because that is the most common site of actually tension of infection. And one need to scoop out all the biofilm or the slimy layer, those are present, because that will prevent the penetrate of the antibiotics, and particularly the pack should be removed. We normally use a brush, or sometimes you can use with a, that means gauze piece, you can just remove everything with betadine and hydrogen peroxide. Then you need to wash out both the medullary cavity, femur, as well as the tibia, and we re-meet and remove all the necrotic or dead material. Sometimes we have noticed that even purulent material can be found there. And then we soak it with betadine and keep it for 5 to 10 minutes for action. It has to impact on both the sides. Then we wash it with pulse lavage, and then we measure the flexion and extension gap. So this is the extension gap. Here it was found to be 13 mm here. And in the flexion also, we noticed that it is 13 mm. So probably it will be a well-balanced spacer here that we are going to make. So then you should redrape it and then use vancomycin to the bone cement. We normally use 4 gram of vancomycin to 40 gram of bone cement, and normally 2 packs of bone cement are minimally required. We prepare one of the stem for the femoral side, and then over that we put the bone cement in the dowel phase. And you need to shape it using a tibial insert so that the medial cam and post of both the tibia and the femoral sulfate will match there. So extra cement has to be removed because it may damage the collateral ligaments. So it should not hang from the condyles on both the sides. Similarly, on the femur tibia side also, one need to put one stem there for the tibial stem on the lower side, and you need to remove extra cement, and along with the femoral component, you can shape that. And this is the patellar tracking. Once it is set, you can check that and you can go for the closer. So if you see the evidence, probably there is no difference in the functional outcome after static or dynamic spacers in revision TK when we are dealing with the infected case. There is no evidence that pre-made spacers have any superiority over homemade spacers, and the amount of antibiotic may be up to 20% of the total mass of the bone cement, as the mechanical strength of the spacer is not a major issue. And when you are going for the final fixation at the second stage of the procedure, the ideal amount of antibiotic has to be 10% of the cement. So thank you. Thank you, Doctor.
Thank you, Dr. Sujit, for keeping it concise and to the point. You have given appropriate instructions. So meanwhile, as you stop
Can
sharing,
you stop sharing? Yeah. Okay. Okay. Go ahead. Go ahead.
and we can ask Dr. Tarun to load his presentation.
In the meantime, we can ask all the faculty, how many of them go for a static and how many of them go for dynamic?
I'd go for a dynamic spacer.
Likewise, articulating spacer, always.
I also go for articulating spacer.
Okay, the majority are.
I go for a static spacer because it's a difficult thing to remove them, you know, the articulating spaces. They're not easy, especially if they put a peg inside the medullary canal. They're quite difficult to extract during the second stage.
Yeah. Even actually, I was also using a lot of articulating spacers, but now moved towards static spacers. A couple of things is at the end, how good your skilled enough to mold the articulating spacers. If not, you are not using a ready-made because ready-mades are costly, sizes are a problem. Having said that, now with some literature also supporting this static spacers, the eradication of infection, and because there is no big difference between the functional outcome, whether static or dynamic, you get the movement. When you get the second revision, you don't have the issue with the movement. So in 6 weeks time or 2 months time, if you are doing the second stage, I don't think static has got any issue with movements. But in regards to control of infection, stability and soft tissue healing, all those things with the static spaces, even myself, I'm feeling some good difference with the static. So I have now moved towards static spaces.
Can I ask a question, please, to the faculty?
Yes, yes.
Yeah.
How many of you actually use this technique where in the spacer itself, you make multiple, like pock marks, indentations in the spacer? Because there is a paper which has shown that the antibiotic elution is much, much higher if you are actually making, because it increases the total surface area of the spacer itself.
Okay, good. That's good.
Yeah,
That,
yeah, that is
multiple indentations within the while it is setting, you make multiple indentations to which it actually increases the total surface area, and total antibiotic elution has been shown to be more than the ones which you make a smooth spacer, you know.
okay. Right.
Dr. Rajkumar.
Yes, Dr. Deepak. Yeah, he's here,
Yeah.
the master of spacer. Sorry, we didn't.
No. But I'm
Please.
just, the point is what you said, the skin cover. When there is an issue of skin cover, you need to have a flap or a skin graft, because in a revision cases, sometimes then static spacer is the indication.
Okay, that's a good point. Yes.
Especially when you have a problem with the skin cover, you should go for a static spacer. And as you rightly said, at the end of the day, the antibiotic elution and the rate of infection control doesn't make any difference between the two.
But I think you are using regularly these dynamic spaces, and you have got some custom-made good way of doing it.
Yeah, the advantage what we have is that we can increase the poly thickness. So we just measure the gap, flexion gap, and according to the cement spacer thickness, we can increase and adjust on table. So we just get a better stability.
So in a post infection in a TKR, how many grams of cement do you totally use for a custom-made dynamic spacer?
So 1 pack cement for the femur, 2 pack for the tibia.
Okay, exactly why that reason? Can you just explain for youngsters?
No, because we have a mold there. That mold takes that much of cement. If we want to extend the rod or something, then we take the extra cement. But the mold which we have, they're autoclavable molds. So it takes that much of cement, which I think is sufficient. Except, as I said, if we increase the poly thickness to 22.5 or A17, or usually in the flexion gap is more, and the gap balancing, if we want to have a more, then probably we have to use a more cement. But up to 15, the 2 pack cement for tibia is okay. If the poly thickness is more, we have 1 more pack.
And do you add antibiotic beads?
Antibiotic beads, most of the cases, yes.
Dr. Unmesh, do you routinely add antibiotic beads?
I used to use it, but I think there's a higher risk of infection. Some papers have mentioned that it increases the risk of infection. And IV antibiotics is good enough to go with rather than the beads. I don't use it routinely nowadays. No.
So I'm going to ask one question to all the faculty. Has anyone actually ever used the same extracted femoral and tibial component, autoclaved it and reused it as a spacer?
I've been using it autoclave for years, and it works very well.
It works very well. Even we use it quite frequently.
I use a RP insert. RP insert is a good for tibia. Just put a RP insert on the cement, a loose cement, and it works very well for article spacer.
Nice.
I think
Dr.
there is
Martin,
a
Yes, Dr.
may
there
Deepak.
is a very well-known documented papers for femoral autoclavable implants, but in the Europe, they banned because it is not officially allowed to use the autoclavable implant to put it reinsert back. So that was stopped because it was from Hoffman who suggested the autoclavable femur at 100 temperatures for this minutes. But in Europe, it was banned because you are not allowed to put that femur back. But now there is a new technique which is 1.5, where they use a new femur.
Okay.
They use a new femur. Again, it is considered not as a one-stage revision. It is known as a 1.5 stage revision. So people have been using it. In our country, probably using the autoclavable femur should not be any problem. But in Europe, it is not allowed to do that.
Maybe the surgeon is lucky. The patient may not even come for a second revision after with all these things.
That is the whole idea for the 1.5.
So
I got it.
terminology,
Dr.
which
Rajkumar
has
said
come.
correctly. Dr. Rajkumar also saying correctly, even our patients sometimes don't come back after reusing the autoclavable femur. So that's the problem.
But
Yeah.
it's a double-edged sword. If we are using a new implant and if it again
Yes. Yes.
the issue becomes problematic, then if you are not able to control the infection, cost escalates. So many things are there. So it all varies from patient to patient. We have to take a decision on table. So we have to be well versed with all the three techniques: static, dynamic, and new implant, so that we can customize according to the patient, affordability, everything.
Agreed.
So thanks.
Great
We'll
discussion
go on to the
going
next.
on.
Thank you.
But we'll have to move forward.
Yeah.
Now we have Dr. Tarun Goyal. He's going to take us forward to stage 2 revision. Dr. Tarun, please proceed.
Yeah, good afternoon, good evening, everyone. So I'm going to present a stage 2 revision for this patient. My presentation is on a stage 2 revision. So that is after infected TKR. So this is a 58-year-old female who had undergone stage 1 revision already for an infected left total knee arthroplasty. She presented with a discharging sinus and obvious signs of infection, for which an custom homemade cement spacer was inserted. And after 2 months, she has been taken back for resurgery for stage 2. When the signs of infections has subsided, the ESR and CRP has gone back to the normal value. So these were the radiographs of this patient at this time, where you can see the cement spacer in place, and this is the exposure. We have already discussed a lot on the exposure of these patients and the skin incisions, what to use. And once we have reached the suprapatellar pouch to remove all the synovium, send material for biopsies and cultures. And this is the spacer that we generally use in the suprapatellar area of the femur. So this is articulating with the femur, as well as it has a broad extension in the suprapatellar area, just to prevent adhesion, so that the future exposure becomes easy. So this extends also to the medial and the lateral gutters around the femur, and also the suprapatellar area. And once we remove this spacer, we really don't have to dissect a lot to create the gutters on the medial and the lateral side again. And we excise whatever synovium needs to be excised and recreate the middle and the lateral side, and then start with the medial release, as was told by Dr. Arora, and up to the posteromedial release. Once you have released this much of on the tibial side, it becomes very easy. We really don't make any attempt to evert the patella, which is absolutely not possible in this type of cases. And we have enough exposure. We are measuring the distance from the tibial tuberosity to look at how much joint line restoration we are looking at, what is the amount of defect we are looking at on the tibial side, how much we have to reconstruct. And this is most of the times it is in the range of 3 to 3.5 centimeters normally. So we know how much poly thickness we are looking at on the tibial side, because we really don't want very large poly and we really don't want to elevate the joint line. So this is a tibial preparation. So in this tibial preparation, once we have prepared the canal, we will look at whether we need any eccentric components on the side, whether we need any offset components on the side, or is the tibial base plate that you have sized on the side is exactly in line with the medullary canal. And once this is done using the intramedullary system, we have taken a very minimal cut on the tibial side of the tibial plateau, because we don't aim to reach at the base of the defect, but we want to reconstruct and restore whatever bone stock is left with us. And we are going to complete the rimming and broaching on the tibial side after the sizing. And in this case, we didn't have to use any offset components. Now exposing the femur, we are marking the epicondyles for the rotation alignment, because here we generally on the lateral side, you may see more often on the lateral side, you may see bone defects both distally as well as in the posterior condyles. So rotation, if you look at the posterior condyles, may not be reliable. So marking epicondyles will help. This is the locating the femur intramedullary canal and sizing the femur in the medial lateral direction. In anterior posterior direction, it may not be always possible to measure the femur dimensions, because you may be encountering bone loss on the femoral side. This is creating the canal on this side, and the amount based on the length of your intramedullary rod you're looking at, you'll prepare the canal. And this is the LCK system by Zimmer, and we are preparing the anterior and the posterior cut along with rimming the medullary canal. Again, on this side, we have used the centric zig because we didn't need any offset depending upon the alignment of the femoral component. Sometimes you may need offset components, so they should always be available with you when once you're doing a revision arthroplasty case. Preparing the femoral canal with the different sizes of the reamers, and the proximal most reamer is the largest one to accommodate the distal femoral component. And again, we'll see the amount of bone loss that is present, and also measure and have an approximate idea of the flexion gap that we are going to look at. How much flexion gap we are looking at in this patient, and what is the amount of bone loss on the posterior medial or the posterior lateral condyle. So in this case, we can see that on the posterior medial side, there isn't much defect, but on the posterolateral side, a blade was not touching the bone, and definitely there's a defect on the posterolateral side. We are completing the chamfer cuts. Once we are completing the chamfer cuts and the box cut, we'll realize that very little bone is generally removed in the anterior chamfer cut. Maybe a little bit of bone is removed. We'll just have to brush through the bone in the posterior chamfer cut, and but some amount of bone is removed in the larger box cut that we are making here for the large femoral tibial keel. A very little bone or no bone is generally removed in the anterior chamfer cuts in these cases. In most of the times, we'll see that. And a little bit of bone is removed in the posterior chamfer cuts in these cases. Again, this is the femoral component in place, and we can see that there's a defect on the posterolateral side of this component. And the horizontal lines on this femoral component will also tell us whether it's a 5 millimeter gap or a centimeter of gap that we are looking at. And if we look at on the medial side, on the opposite side, there was no defect on the opposite side of this. On the opposite side, the femoral component, the trial was absolutely touching the bone both anteriorly and posteriorly, as well as distally. The tibial component, the tibial trial, the femoral trial has been in place and secured in place. And again, we are going to measure the flexion and the extension gaps. And as was the need in this case, we'll scale up the poly insert if we don't find the stability is good enough for us. The flexion and extension gap should be matching. There should be no recurvatum. There should be, this is the offset component. So the offset direction can be adjusted as per the need, depending upon the location of the intramedullary canal in relation to the tibial or the femoral component. And similarly, the offset stems will have to be in place. You can see the offset stems, the angle of the offset stems will be adjusted according to the location of the intramedullary canal. again, a generous cementing is done. Generally, we would like to do the surface cementing as well as we would like to cement the metaphyseal part of the keel as well as the proximal most part of the stem that we are going to place. So there's cement in the surface as well as in the metaphyseal part, and both the components have been placed. And here we can see the post-operative radiographs. There was a small defect on the medial side, which was only anteriorly, which was about 3 to 4 millimeters that we have managed with screws. A larger defect may need augmentation with a tibial augment on the medial or the lateral side, depending upon wherever the defect is present. And once we put this LCCK inserts, you will have to secure them with a screw, again confirming a flexion and extension gaps. Thank you. My video ends here, and I would like to have any questions.
Thank you, Dr. Tarun, for your excellent video presentation. So I would request you to first stop sharing the screen so that the next speaker can upload his screen. So Dr. Ankur, please share your screen. Meanwhile, there are a couple of questions. We can tackle them.
Yeah, you've disabled participant screen sharing. It's saying.
1 second. Dr. Tarun, can you just summarize your main points of stage 2 revision?
Ankur, you can do now.
Yeah. Yes, sir. Thank you so
Yeah,
much.
stage 2 revision, we are looking at encountering, once we looking at the intraoperative steps, we need to see what bone loss we are looking at. And again, restoring the joint line and restoring the bone stock that we already have should be the priority along with the alignment. So the principles of arthroplasty remaining the same. Will try to use the minimum constraint possible with maximum restoration of the articular surface, the bone stock, and try to preserve the joint line on the tibial side. Do not elevate the joint line.
All right, perfect. So let's start, Dr. Ankur. You can start your case and we can do more discussion if the time permits. Please go ahead.
Ankur, keep it.
Yeah, sure. I'll keep it short.
Yep.
Thank you, Team IA, Dr. Rajkumar sir and Dr. Ajit sir for providing me this opportunity. So, a 67-year-old male came in the OPD with a history of pain in the right knee since 1 month. He was not able to walk since 1 month. He had undergone a bilateral TCAT 1 year back, and he had a history of fever spikes on and off since 1 month. On clinical examination, swelling was present on the right knee with tenderness. There was no discharging sinus. The blood perimetry shows raised WBCs. CRP was 97, neutrophils 90%. So this was the clinical picture in the pre-op X-rays. So what I did is I aspirated the knee. It was positive for methicillin sensitive Staph aureus. So naturally Drix was planned. We removed the implant and the cement spacer was put, and he was kept on IV antibiotics for a period of 6 weeks as per the sensitivity, followed by the oral antibiotics. After an antibiotic-free period, serial CRPs and WBCs were done, which were normal, and patient was counseled for a revision TKR. So these were the intra pics. I did a sleeve over the tibia part and augments on the femur. So you can appreciate he had undergone a range of motion of 90 degrees, no extension lag. This is the post-op video of the patient walking comfortably, and this is a stair climbing video. Thank you so much.
Thank you, Dr. Ankur, for the case. May I ask, what is your cutoff for your CRP levels? What's the cutoff value you use for the CRP levels?
So if the patient has come to me in the OPD and if the CRP levels are 10 or above 10, especially if the patient is 1 year post-op, I would definitely suspect some sort of infection.
Acute?
Yeah, it can be, no, if it is an acute hematogenous, probably the CRPs are raised more than 10, like maybe 50 or 60, if it's an acute hematogenous, just like in this case. But I've come across one patient in which the CRPs was only 10. And still he was having pain in the right knee since the primary knee was done. He was undergone on both knees, but on one knee he was taking analgesic since last 1 year from the date of primary surgery. And at that point of time, so it was a chronic infection. And luckily, I did a USG guided aspiration over the point of maximum tenderness, and I could find an organism which is methicillin. It was a staph epidermidis, methicillin resistant. So for chronic infection, I think 10 is okay, but for acute, it is more than 50 around, 30 to 50.
So have you done this? Is this a single stage revision?
No, sir, I have not. I have not done it.
No. This is you have put a Siemens spacer and you did later on, or
Yes. It's a 2-stage, sir.
okay, it is 2-stage. Okay.
And what is your antibiotic protocol? I see you have used.
Can you stop sharing in the meantime, Ankur?
Yeah.
So.
Does anybody do frozen sections?
It is actually it can be done, but the only thing is sometimes it is also not very reliable. It has to be a very good teamwork. You transport the medium very quickly to the department, pathology department, and there also be aware of there is a case which a frozen section is going to come, and sometimes it's not very reliable also. Like if in a doubt that maybe or may not be in that kind of a situation, then it is okay to make a conclusions, make some sort of decision whether to do a 2-stage or a single stage.
Sir, can I ask one question? So in case if the aspirate doesn't come out to be anything, like no fluid has come out, how to go about it? And in case of culture negative, like we have sent a fluid, there is no organism, because most of the patients who come to us in a 2-tier city, they usually have a long-term antibiotics, and see we didn't find any organisms. So in these two scenarios that we don't find any aspirate on aspiration, still the CRPs were like particularly in chronic infection, like 1 year post-op, CRPs are more than 10. We are not finding any aspirates. And secondly, if we did find an aspirate, but it's culture negative.
See, that is actually the situation is a little bit dodgy. Like you have to go by multiple things. First is the clinical scenario, how severe is the pain, then the radiological findings, and also if the patient is on long-term antibiotics, and then if you are doing an aspirate, if you are not going to grow anything. So you give us a patient some time of 1 month, 3 to 4 weeks of complete antibiotic-free period. Then again check the ESR CRP. See, 10, 11, 12, maybe not that conclusive. You need not, just because it is 11 or 15, you should not be very much doubtful towards infection come immediately. So it's all comes with the multiple things, whether effusion is there, some sort of instability is there, go for good radiology exercise, stress views, and then over the period of time, if the patient is continuously having pain, then you have to, even if the culture is negative, then you have to go for some sort of procedure. You open it, then you can say the patient that if it is not really infected, then you can go for a single stage revision, or if it is a doubtful infection, 2-stage revision. But till that time, you have to be very much in a combination of clinical, radiological, and antibiotic free aspirate and extended culture.
Okay, thank you, sir.
All right. So all in all, it's a combined clinical radiological scenario. So you have to decide seeing a lot of parameters. So meanwhile, Dr. Pandey is ready with his case. It's an interesting case of bilateral revision TKR. So I would invite Dr. Pandey to take on the stage and start presenting.
Yeah, can you hear me?
Yes, sir, perfectly.
Oh, good evening, everybody. I'm Dr. Pandey. I'm going to present a case, 72-year female, and she was having pain, instability, both knee for 1 year, pain on weight bearing, no pain on rest. There is no history of fever. Index surgery was done 22 years back. Actually, this case is of 2020. Okay, but the first surgery was done in 1998, and the medical comorbidity was diabetic and hypertensive. On examination, the temperature was normal, range of movement 0 to 140 degree, whereas valgus instability was present in both knee, and there was no distal neurovascular deficit. And this was the weight-bearing X-ray I've done in my OPD. After 22 year of surgery, there you can see on weight-bearing, there is a asymmetrical joint space, more significant on right side, but less on left side. This is, you can see there is some lashes middle side on the left side, and posterior femoral side here, you can see there is a bone lysis. So ESR and was 32, CRP was 5.10. As on aspiration, it was sterile. The count was normal, within normal limit. And now the question arises whether to go for simultaneous bilateral revision total knee or stage wise. Considering the patient's physiological status and the echo, ECG, and the other parameter was normal. So I have planned for bilateral simultaneous revision total knee replacement. And I usually follow the AORI classification, Anderson Orthopedic Research Institute classification, after removal of the implant to build the bone defect in revision scenario. Although so many has been talked about the revision, how to remove the implant and how to build up the joint line, how to fill the bone gap. And on removal, there was asymmetrical polywear. You can see very well significant here. And this was the immediate post-op surgery done in 2020. The right side, I have used the bicondyle wedge, and the left side, the medial wedge has been applied. Although I would have loved to use the sleeve, but because of the cost constraint, I have used these wedges and metaphyseal intermediary extension rod. This is the lateral X-ray, and this is the length and diameter of the stem. Although I put the question, there is no ideal length defined. Improved stability with a canal filling presbytery stem, 98% survival at 12 years. This is the Wood et al. And recommended canal filling ratio is more than 0.85. The aim is at least to 4 centimeter of diaphyseal engagement, but there is no clinical evidence of reconciliation between the stem length and the diameter. So there is no ideal length, there is no ideal diameter, though it should have at least the 4 centimeter diaphyseal engagement, and the canal filling ratio is more than 0.85. So this is the joint line landmark, which has been already talked about. And just day before yesterday, I have asked the patient to send the video. This is 3.5 years after bilateral revision total knee replacement. This is a video patient has sent just day before yesterday. So the question arises whether to go for simultaneous bilateral revision total knee replacement, whether it is medical legally safe, or go for stage wise. What is the view of the our speakers here?
It's, I think, little difficult decision making. Probably most of us would go by the most symptomatic knee first.
Okay.
Because the right knee definitely looked more involved. The left looked reasonably stable. And it all depends on the symptoms and the disability that the patient has, I guess.
Okay. In our case, the patient was having more symptomatic on both sides. In fact, it was highly unstable. When I examined, the both side was highly unstable, and there was means mediolateral instability. So because physiologically she was looking good. So I planned bilateral simultaneous revision totally.
That's a good case, but whatever it is, for all practical purpose, particularly in an aseptic situation like this, to go for a single stage bilateral revision is really a brave surgery, not for everybody. And the take home message I feel should be a little bit cautious and not to venture into this, because
Yeah.
every time you might be able to get away like this. If suddenly one was infected, then it puts risk for both the knees. So that becomes a
Yeah.
big challenge. So then that is a riskier one. So otherwise, it is safe to do one by one.
Dr.
Okay.
Pandey, would you not
Yeah.
think that it would be wise to just have a varus valgus stress view to document what you stated as instability as a reason, say that God forbid if there was a problem in the future, you had something to back up with?
The weight bearing X-ray is already showing that there is a almost contact of the metallic surface of the femur and tibia. You can see it very well in the
On the right side, yes, but I
X-ray
was
on
talking
the
for
right
the
side.
left. I was talking
On the
about the left.
left side was patient was saying that there was a much more pain and instability, and you can see a little bit loosening on the medial side of tibia and posterior of the femoral. So at any way, we have to do the bilateral means both side revision. So considering the physiological status of the patient and there was not a much echo changes and LFT, KFT was normal, albumin was normal. So just I arranged 2 unit of PRBC and gone through the revision.
I would agree with Dr. Rajkumar saying that you have been quite brave here.
Yeah, I usually do a lot of bilateral simultaneously. This is my third case. And in 2020, I found that in India, it was the fourth case, I think.
Ashish, the next speaker can load
Dr.
the.
Kunal, please load your screen.
Can I ask one question to Dr. Chandrasekhar, like regarding CR-knee on this platform?
Please,
Yeah.
please.
Yeah,
Yeah.
so if you are doing a CR-knee in a primary case,
Yeah.
and since we have seen sometimes patient had a fall, especially on low lying sitting and suddenly getting up, and we have instability or maybe PCL rupture. So can't we be proactive, like putting a deep dish with anti-resistant poly in first case, so that even if something happens to her, God forbid, she won't be having instability later on in the life, maybe 5 years post-op or 10 years post-op.
Definitely, if on table, if you feel that it is unstable, then I wouldn't hesitate to go for an anterior restraint, anterior stabilized.
Even sir, even if it is stable, for the future purpose, right? Maybe 5 years down the line. I mean,
If
even
that
we
is
have
the,
not released PCL, everything is
If it is
fine.
stable, then I don't think you do it as a prophylactic measure, because it's again a kinematic conflict. Because basically, if your PCL is good enough and you are using this as a restraint, isn't it, to prevent any posterior subluxation? So the PCL is already, if it is good enough, if you think you haven't resected any part of the anterior fibers of the PCL, sometimes if your tibial cut is very low, some of the anterior fibers of PCL sometimes inadvertently get cut. So in those cases, if you are not very sure, then maybe you can go. But if you are very confident that it is stable, there's no need for routinely going for an anterior stabilized insert, just
if
as a
that,
prophylactic measure for future.
Okay.
in that 2 points are there. One is all systems doesn't have this
Yeah,
deep dish
exactly.
insert. So you
Yeah.
have to be careful. But still,
Okay.
if you're in doubt, better to do straight away a PS knee rather than thinking
Yeah.
about all these dishes.
Okay. Thank you, sir. Thank you.
So perfect. A lot of thoughts-provoking ideas. So, Dr. Kunal, please proceed with your case, and maybe you can just stop after presenting the case scenario before you start presenting what you did.
So, good evening, everybody. Warm greetings from Kolkata. Thank you for giving me opportunity. Thank you, senior members. So, my case is revision TPR for unstable knee with periprosthetic fracture. So, 64-year female patient is a known rheumatoid, no comorbidity, having her right total knee replacement done in 2006, and she has a periprosthetic fracture fixed in 2016. and implant removed in 2020. So this is her first X-ray after her periprosthetic fracture, which was fixed with lateral plating. Both are done elsewhere. Sorry, I don't have the first X-ray of the replacement. And in 2020, it has been healed and the removal has been done. The patient came to us in 2022 with unable to bear weight in right leg for long distance walking, with a right knee pain is unresponsive to any analgesics. Clinically, there is no signs of infection. Investigation shows no septic foci is there. So we have done his X-ray. This is an X-ray. So there is clinically there is valgus stress opening up of more than clinically there is a valgus opening up. X-ray showing valgus stress view of more than 2 centimeter opening up. So the problems to be addressed. This is the examination under anesthesia. So there is in extension there is corner instability. So what are the problems in front of us? The first thing is the malalignment due to the previous periprosthetic fracture, and again there is medial collateral ligament laxity. The bone loss we anticipated during the revision, the associated osteoporosis due to rheumatoid and their age, and there is multiple incision, first replacement and then 2 times of removal of the plating.
Can you just stop here for a second and just load the last X-ray? So can we just talk on the issues here?
Okay, so the issues are here is the first thing is we can see there is opening up of the normal X-ray shows fine, but there is osteoporosis around with long screw holes is there, and there is valgus stress view showing opening up more than 2 centimeter on the medial side, and the varus stress view is normal. So there is deficiency in the medial side.
So what could have caused this MCL insufficiency here?
This actually the patient has not have given any history of fall or something like that. After the removal of the periprosthetic plate in 2020, the patient actually developed this thing.
So what would be your thoughts here? What's the most likely cause here? Chandrasekhar, you want to take this question?
Yeah, I mean, to start with, I think the knee was not balanced. If you see the normal weight-bearing X-ray again, there is unequal gaps both on the with more, more opening on the medial side. So the MCL got stretched out over a period of time because she's obese and overweight. So over a period of time, the MCL has undergone attritional rupture, I think,
right,
because of the imbalance at the index, the index surgery.
That makes more sense. So
that is also there. And one more point is patient has got now some malunion. So fracture, malunion. So that has put on a lot of stress on the MCL, which has got stretched out, and now it has become lax and it is opening on the stress views also.
So moreover, after periprosthetic fracture, the first time, there is always a chance of some MCL injury also. So
yes, please go ahead.
And the next issue at hand will be the different incisions that we have. So probably we'll have one midline and one lateral incision.
Yeah.
Yeah. And they should be adequately spaced. So
yeah, adequately spaced, and
so,
already 2 years has been elapsed.
Right. And what the bone loss? You're saying what are thoughts?
We are anticipating so this patient needs revision. We are anticipating there is a bone loss during revision scenario after removal of the prosthesis.
Right. So you'll be keeping all the armamentarium as you've discussed.
Yeah.
And so let's proceed. What you did.
So this is the Zimmer Osseo TI implant after removal. So we had used rotating hinge prosthesis. So this is a post-operative X-ray. So we have used sleeve and augments also. But one thing, this is the shortest sleeve we have got in our OT. But the bone quality is so poor. You can see that the sleeve is actually abutting the anterior cortex.
Right.
So, but we have advised the patient for not to wait there for next 6 weeks. But during turning in the bed after 18 days, the patient got this kind of fracture. So it's a Rorabeck type 2. The implants look stable, but the fracture is displaced. So now we have the options of either going for ORIF by single or dual plating, or like megaprocesses like LPS or restores. So we keeping all these armamentarium in OT, we see that this the sleeve is quietly adherent to the bone, the distal part of the femur. Implant looks very stable. So we opted for dual plating, one medial subcutaneous plating and lateral plating. So this is our immediate post-op X-ray. This is our 9-month post-op X-ray. So this is the first the patient presented, and this is the 9 months follow-up after the operation. So take-home message is keep reduction in neutral varus and valgus and mind the anterior brow always. If it is a periprosthetic fracture, fix it well, preferably both sides, and always keep concern about the associated osteoporosis. Thank you.
Great case, Dr. Kunal. Any thoughts what you could have done in the first revision, or what might have caused the fracture? Just the poor bone loss, or anything else might have caused the fracture?
I have already said that because this is the smallest sleeve we have available. So we have tried for giving a stem, but as the sleeve is also abating, the stem will must be abating the anterior cortex. There is a chance of perforation. So I think we have made the mistakes during putting the sleeve there, that touching the anterior cortex, and most probably the associated osteoporosis. That makes that periprosthetic fracture second time.
Definitely a good case and very well taken care of. You have come out.
Can I make a point here?
Please.
Sir?
Basically, once we have seen that the sleeve is very tight and there could be a small microfracture, you could have wired the femur there, and could a protective plate could have been put in on during the surgery itself, just to avoid this fracture. That's all.
Thank you, sir.
Great case, Dr. Kunal.
Thanks, sir.
Please stop staring, and I'll invite Dr. Sahil to present the last case of the evening. It's on role of allograft processes construct as salvage and revision TKR. Dr. Sahil.
Yes, sir. I'm just sharing it. Just sharing.
Perfect.
Just a moment. Actually, I'm not able to share it. Just a moment.
Maybe I can just put put a question forward for some discussion. For periprosthetic fractures, what would be the best approach that we should use? A lateral approach, or we just go and extend the anterior midline and try to consider for dual plating if required? So maybe. So anybody who wants to take up this question, Dr. Prasad, if you are available.
If for periprosthetic, I will use 2 incisions.
So you would go lateral and do the lateral plating.
Yeah.
And if need be, you will go a medial approach for a medial plating as well.
because that fixation has to be rock solid. And usually we prefer to do a long lateral plate and a small medial plate. And the long is really long. It should go up to the subtrochanteric area.
Right. Any difference of opinion amongst the faculty?
Yeah, Ashish and
Please,
Dr.
sir.
Rajput here.
Please, sir. Your
Yeah,
comment,
so
please.
the trend now is to actually, do a combo fixation, preferably a nail and a plate combination. So lateral plate and a nail. The question is, you need to be very sure about your implants that there is a space for putting in the thing. So the older knees which we had, many of them, particularly the smaller sizes, didn't have enough box width. But if you look at all the modern ones, the box is almost disappearing. There is a space for a box, but there is no actually hard box there itself. So the modern ones, even the PS designs have, that's why they change, because of one eye on the periprosthetic fractures. So if you look at all the trauma surgeons who are operating on this, they prefer, and they have got, these are called extreme nailers, by the way. So this is a special branch coming out now called extreme nailings, both on tibial side and on femoral side. You need to put one nail and one plate combination. But barring that, if you don't have that expertise or you don't have that combination, dual plating, I think, is the way to go forward. There is still a place for single plates, but that incidence is gradually falling down further and further.
Yeah, the case, PPT is ready.
Yes, sir. Good evening, everyone. Dr. Ajit sir, Dr. Rajkumar sir, and Dr. Ashish, thank you for giving me an opportunity to present this case. My case is on allograft processes reconstruct as a salvage position in revision TKR. So, with the advent of cones, sleeves, and all, is it the end of allograft era? We definitely don't think so. And my mentor, who has taught me over a period of time, we doesn't think so. We do a lot of more allograft cases. So this is a female 25-year-old who was operated for GCT in 2009, then again reoperated for recurrent GCT with mega processes in 2012. She was asymptomatic for 7 years and again presented to us in 2019 with pain in the left thigh. This was her X-ray when she presented to us. You can see the obvious loosening on the femoral side and with an impending fracture, and so it was a diagnosis of loosening of femoral component. So we did a bone scan to confirm the diagnosis. ESR CRP was normal. She had pain in left, so we need to revise. So we had a bone defect of more than 10 centimeter. We need to fix in the proximal canal also, where already there was cement and all, stem was gone, and she has a younger age group, 39-year-old. So she may require a future surgery, we all know, and she also had her activities of daily living to be carried out. So the plan was either total femur replacement or what we do allograft processes composite APC. But for total femur replacement at the age of 39 is no to us. So what we did, we removed all the implants, did Synovasure at that time. It was more of a thing to do. Nowadays we don't do it. So it was negative. So on the back end of the table, we prepared on an distal femur allograft. The TKR was performed, non-modular hinge, and all the cement was removed. The canal was thoroughly under C-arm guidance was irrigated, and impaction bone grafting was done. So you can see how the impacted bone graft allograft was done. Then the allograft along with the implant was fixed with the bone, and cementation was done, and we used fibular stud to enhance the healing using control cables. So this is the post-operative radiographs of the patient, and this is at the 3-year follow-up with showing complete union at the host and bone junction. So this we have published our literature comparing mega process with allograft APC. So what I have to say that although mega processes allow early weight bearing and it has decreased risk of mechanical complication and decrease of infection, but APC do carries their own benefit in terms of restoring bone stock, better functional outcome, cost effective, and it definitely gives an edge to have another surgery with improved bone stock. Thank you.
Thank you, Dr. Sahil. It's an excellent case to discuss. And if I may ask, your one prime indication for using APC and one contraindication.
Sir, we have done cases in young patients wherever we feel the proximal femoral or distal femoral bone loss is more than 10 centimeter, we opt for APCs. And contraindication as such is apart from in where we can do mega processes, we do APC. There is no contraindication apart from that thing.
So I would probably take home the message that in a young patient with a lot of femur bone loss or tibial bone loss, we can think of doing a APC.
Yes, sir.
That makes the point clear. So this case is open for discussion. I would invite all the faculty to kind of put their comments.
Yeah, it's actually a very good case. The only thing is it is more of the options available. So if you have the sufficient allograft for an impaction bone grafting, then allograft for the distal femur allograft, and then the expertise to do the fixation, the plate fixation. And if all these things are available, I think definitely in a young patient, in a non-septic situation, this is also a good option. That's a very good technique.
Dr. Rajput, you want to put a comment?
For the allograft, yeah, I think Rajkumar has made a very valid point. You have it, you try all this. But I don't know, even in their center, when was the last time they did it actually? So it's not something to be ventured very easily. But as a last option, there should be one option we can fall back on. But it's just the expertise available is just very daunting.
Maybe as Rakesh said, I think if centers which has got bone bank, and if they're all doing this, maybe we all should start reporting that this is being done, like what Sahil has brought it out like this. So in these kind of platforms, if it is routinely presented, these kind of cases, I think it will be an eye opener, and it'll definitely it'll help in restoring the bone stock. The mega processes is not a one-stop solution for everything. Like I've seen so many cases, mega process, custom made processes, loosening, coming with the patients coming with loosening in an early stage. So definitely this is a good way to look things forward for future revision surgeries.
Great point, sir. Maybe have some comment from Dr.
Sir,
Sanjeev, and
can
then
I ask one question?
Please go
Yeah,
ahead.
please.
Yeah. So I just want to ask, like, the limb preservation process is suppose for GCT, how long it lasts, and suppose it get loosened up. So we can use APC in this case once the mega process is loosened up, or we have to do something else, like with such massive bone loss.
It all depends upon how much of bone loss is there. So the problem with this mega process is it not only the bone loss happens in the portion where the stem fixation happens. So how much of bone loss, how much of cortex is available, then you have to really do a thorough planning, and what kind of further revision. Then finally you will end up in a tube, proximal femur or a distal femur replacement or an entire femur replacement. So then everything escalates, and also considering the age of the patient, try to be as conservative as possible, but we have to weigh down what are the options. So that options are very, very limited in a situation like that. So it all depends. If that is the case, it is better to send the patient to a expert center where they are dealing these kind of cases routinely.
Thank you, sir.
Great. Maybe some closing comments by Dr. Ajit Kumar. Professor Ajit Kumar.
So Ashish, I had put in the one of the questions actually, that how many of you routinely use CM in OT? And I think Dr. Kunal's case was a very important point to tell you that, you know, if you don't have CMs, you will end up in trouble. So I know many people don't use it, and many of them are against using it also, I've seen. Because I'm talking about forum where a lot of foreign speakers also have come, never used CMs. But I think for our cases, and our scenarios, it will change gradually. You will see that we should have CM available, and perhaps just have a quick shot before you finally close it. You know, when you're doing trial, have a quick shot where you are.
One comment. I think Rakesh has made a very good point. I use always CM for before I close, because you never see any eventual fracture or something like that. So it is worth having a CM view before you close. Yeah.
So this thing is not just for the before closure, even when you're putting a trial component, I heard one speaker talking about offset stems. So you can actually dial in your offsets to make sure that your stem is not hitting against any cortex. That's the time you can actually do your final adjustments.
Yeah.
Looking at this, yeah.
Especially in
Yeah,
our scenario, yeah.
I have seen like a couple of times the stem size was 12 on the tibia. It was getting me in a varus, slightly varus the sleeve. So I could change to 14
Change
or
it,
something like
yeah.
that. So I know what's happening inside before I do anything about it. So I think it's a good tool I always use for revision surgeries.
It's always better to have it in one thing in mind, whether it is a primary or a revision. Whenever there is a doubt, don't hesitate to use a CM.
Yeah.
Right.
Perfect. So great discussions, great cases. I hope it was useful to all who attended, and I would like to thank all the faculty, Dr. Raj, Professor Ajit, Dr. Sanjeev, Dr. Rajput, for being there and guiding me through this. And maybe I would like Dr. Ajit Kumar to have a closing remark.
The secretary will do the closing remarks.
No. There is not. Please, Dr. Ajit, please go ahead.
No. I think it was a wonderful session. And see, the important thing is more and more youngsters are coming up, and right across the country we have had presentations, and that bodes well for the fraternity. I think we've all gained a lot from most of the lectures and the cases. I'm grateful to Dr. Ashish and Dr. Rajkumar for putting up this program, and to all the faculty for making the time and effort for this. Thank you.
Yeah, thank you, one and all. And as Dr. Ajit said, I think this was a very good webinar and a good discussion. And I know TKR revision is a very common topic in every meetings we speak, but in every meeting we come up with one good points. And this time, a lot of new faculty have come up with some nice ideas and points. And I would like to thank Ashish and the entire IAA team for having this webinar possible. And I would request every new delegates in this webinar today, if not to become a member, please become an IAA member, so that we all share our knowledge and enhance our skills and fine tune our surgical skills for better outcome of the patients. Thank you.
And congratulations, Rajkumar. I think you crossed 1,000.
Yeah, now we are at 1,004
congratulations.
members. Yeah,
Many congratulations.
Many
very good news.
congratulations, Rajkumar.
Thank you. Oh, Dr.
Great.
Sanjeev is here.
Sanjeev
Yes.
is here.
Oh.
Actually,
Welcome, Sanjeev.
No, I was watching it. I didn't say a single word because it's very nice to see the youngster taking the lead and a lot of discussion happening. So I think it was very nice to see that IA is shaping up very nicely.
Yeah, we know when Ashish